Hi guys, today's topic of discussion is influenza virus. Influenza virus is a common cause of both upper and lower respiratory tract infection. It is one of the common viruses that cause this disease. Among other viruses which can cause upper and lower respiratory tract infection are coronavirus and JC virus, BK virus. So we will take a brief look about the vaccination, the management, the epidemiology, and the clinical features of influenza virus. So we will talk about influenza virus in our discussion today. Uh, besides influenza virus, there is respiratory syncytial virus (RSV) virus. There is HSV1 and HSV2. So herpes, usually we do not think of herpes causing pneumonia or respiratory tract disease, but this is also a prominent cause of respiratory tract infection. HIV. So HIV is notorious for causing pharyngitis in immunocompromised people. So HIV, pharyngitis, and HIV can also cause pneumonia by itself. Besides HIV, human Boca virus and two polyomaviruses, namely JC virus and BK virus. Okay. So just a brief overview about influenza virus. It is an RNA virus and it is a single-stranded virus. The family it belongs to is Orthomyxoviridae family. There are three types of influenza virus. The three serotypes of influenza virus are influenza A, influenza B, and influenza C. So in our discussion, we will be only talking about influenza A and B because influenza C does not cause disease in humans. So influenza A and influenza B are the responsible for causing serious disease in humans. Okay, so you must have heard of the various swine flu virus, Hong Kong flu virus. So these are all different names of influenza A virus. Influenza A virus has H protein and N protein on its surface. So H protein has various H1, H2, H3 types, and N protein has N1, N2, N3 types. When the different types of H and N combine together to form a particular combination, so for example, it can be H3 protein and N2 protein combined together to form H3N2. So this is the name that the virus will now have. We will call it as H3N2 virus. Then what is swine flu virus? What is Hong Kong flu virus? So when these viruses cause pandemics, they get the name of the location in which they are causing pandemic. The Hong Kong flu virus means it caused a pandemic in Hong Kong, and swine flu virus means then the name it is getting is swine, pig. So the mode of transmission, which is pigs in that case, it will get that name. So either the location will be the name of the virus or the transmission, the mode of transmission, the animal, it can be a bird flu. So birds will be the transmission animal in that case. So it will get the name of that transmission uh, animal. So influenza A has two surface proteins H and N. H and N have many variation and combinations of H and N will give the name to that virus. Similarly, influenza B does not have any H and N subtypes. It has two types of B lineages called Victoria lineage and Yamagata lineage. ठीक है? Influenza A has H and N proteins. Influenza B does not have H and N. The lineages in this case are called Victoria and Yamagata lineage. When we talk about epidemiology, then the age group that's affected most is elderly people. They will be affected more. Also, young children less than 6 months of age, they are more prone at getting this disease. Besides this, in which weather is the influenza virus transmitted more? It is the winters and in the rainy season. Besides this, what are the other risk factors? Being a male is a risk factor. Having a chronic illness, especially a chronic lung disease, for example, COPD, is a risk factor. Smoking is a notorious, if you have to say the most important risk factor, it is smoking. And besides these, other risk factors are cardiac disease and obesity. Okay, so the elderly and very young are affected more. It is more commonly seen in the winters and in the rainy season. Risk factor is male gender, COPD, cardiac disease, smoking, and obesity. So, how is it transmitted? Through fomites. Fomites means through touch. By touching, when we cough and in our hands the aerosol gets uh, contacted, and then we touch another person, that is how fomite transmission occurs. Besides this, large particle aerosol uh, through coughing and sneezing. If somebody is in direct contact with me, through large particle transmission, the person can get this virus. So it is different from small particle aerosol. It is different from small particle aerosol, which means that if I go through a room and I leave the room, even after 1 hour, 2 hours, the virus will remain inside the room because it is carried by small particles which are suspended in the air. Which condition is this seen in? This is seen in chickenpox. In chickenpox, the virus will remain through small particles inside the hallways and inside the corridors. So that is why chickenpox is so contagious. So as I said, the influenza A viruses will be having H and N subtypes, and these various combinations give rise to different viruses. Okay? H2N1 is the swine flu virus because the pig is the mode of vector. The chief transmission occurs through the pigs. The H3N2 is known as the Hong Kong flu because it caused a pandemic in Hong Kong. H5N1, it is known as the bird flu or the avian influenza because birds are the culprits in this case. Influenza B as such does not have any specific or popular name. It has just two lineages, Yamagata and the other lineage. Okay, now we talk about the clinical features. When you talk about clinical features, we should know that the influenza virus or any other respiratory virus can affect both upper and lower respiratory tract. So what is the definition of upper respiratory tract? It means these are the vocal cords. Anything above the vocal cord is upper respiratory tract and below it is lower respiratory tract. So this is the concept. Besides this, anything you think of in the respiratory system from pneumonitis to bronchitis, bronchiolitis, okay, to ARDS, everything it will cause influenza virus. Besides the respiratory tract, you can see complications in other symptoms. It can involve the heart and cause myocarditis. It can involve the brain and cause encephalitis. It can involve the muscles and cause myositis. So these are the important things to remember which are specific for influenza. Myositis and other encephalitis are not seen in other viruses, but it is seen in influenza virus. Okay, so we talk about first the general features, which is fever. Fever will not be seen in elderly because they are not able to mount an robust immune response. So fever, chills, headache, myalgia, which is generally common to all viral infections. Then we see upper respiratory tract symptoms, nasal congestion, rhinorrhea, sneezing, sore throat, cough, anything that when there is inflammation of the upper respiratory tract, it will lead to sneezing, sore throat, just seen here also. So lower respiratory symptoms and the things that we are talking about, pneumonia, bronchitis, they are more seen in the elderly, immunocompromised and children only. In a normal healthy person with no risk factor who does not smoke, he is not obese, it is unlikely that influenza will complicate. So if it does complicate, we will see pneumonia which can turn into ARDS and the patient can then go into septic shock. If the muscle, the involvement will be seen as myositis. In heart it will be myocarditis, pericarditis, and neurological involvement you will see encephalopathy, encephalitis, transverse myelitis and ADEM. ADEM, you do not need to know what is the, just remember that there is a complication known as ADEM. Okay, so how do we diagnose influenza when a patient comes who is coughing, who has difficulty in breathing, who was recently in contact with a person who has tested positive for influenza, or whose history is suggestive, who has myalgias, who is having fever, headache, and then he developed sore throat. You are thinking this is happening in winters or just in the rainy season, and you are thinking this could be a viral cause, probably influenza, then after doing the preliminary investigations like the chest x-ray, and you do a chest x-ray, you make a diagnosis of pneumonitis. Now you are thinking what can be the cause, then you send the nasal swab for RT-PCR. ठीक है, so we just do not randomly send RT-PCR because RT-PCR is a very expensive test. Only after you do a chest x-ray and you are thinking pneumonitis, the patient is having pneumonitis, then and the history is suggestive of viral etiology, then we send for nasal RT-PCR. Okay, so the most sensitive, the most specific test, just a minute. Yeah, so the most sensitive and the most specific test is RT-PCR via nasal swab. Okay, theoretically gold standard of diagnosis is viral culture, which is not done practically, and supporting investigations are the chest x-ray and sputum studies. Sputum we send to rule out bacterial infection. Okay, one more test that we can do here is we can do a antibodies. We can check for antibodies, and among antibodies we need a rising titer. Okay, serial test, serial testing of antibodies which shows a rising titer can be sent, but gold standard and what is done practically is the RT-PCR, real-time RT-PCR. Okay. How do we prevent influenza? So there is vaccine is available for influenza, which is a quadrivalent inactivated influenza vaccine. Okay, a quadrivalent inactivated influenza vaccine, which is known as IIV. So quadrivalent influenza vaccine is available. Who should receive this vaccine? Okay. The CDC recommends that everybody above the age of 6 months, a child, baby, above that age, everyone should get an annual influenza vaccine. But in a resource limited setting like India, there is certain high risk groups have been made who should receive vaccine on a priority basis in case the vaccine is there is a deficit of vaccine. ठीक है, so in case there is a deficit of vaccine, there are certain high risk groups in India who should receive vaccine on a priority basis. So who are those people? So those people are anybody above 50 years of age, people having diabetes, COPD, any chronic illness. And remember that just having a simple hypertension is not a chronic, it is a chronic illness, but it is not indication for person to receive influenza vaccine on a priority. Healthcare personnel, being a doctor, nurse, working in a hospital, is by itself a high risk group. A BMI more than 40, pregnancy is the most probably the most important the group that should receive vaccination on a priority. Who cannot receive this vaccine? There are only two contraindications. If you had taken a vaccine and you had developed allergy to it, ठीक है, you got a reaction which can either be simple urticaria rash or it can go to the other extreme end of having an anaphylaxis. If you had a history of allergy, it is a relative contraindication to receiving the influenza vaccine, and past history of GBS, because uh, there is a small increased risk of GBS after you get vaccine for influenza. So that is also relative. It is an absolute contraindication to not receive vaccine again. Now the next question comes: when to get vaccinated? So the flu season is in the winters, and it peak of influenza is occurring in November, December, and January. If I give a vaccine today to a patient, the vaccine will take at least 15 days for the immunity to come up. So we need to give the vaccine before November, before the flu season peaks. So ideally, the best month to receive vaccination is September to October. Okay, September to October is the month in which a person should get vaccine for influenza. But there are some states where the peak influenza is not occurring in winters, it is occurring in monsoon in June, July. So in those states where the peak influenza is occurring in June, July in the monsoon season, in those states it is recommended to give vaccine in April to May. Okay, so depending on where you are living in India, in which state and in which season the influenza is occurring, based on that you need to give the vaccine 15 days or more prior to the start of the influenza season. Okay, so what about July to August? If a person comes in July or in comes in August, what to do then? Okay, if the patient cannot come, you tell the patient to come in September, October. But if the person cannot come, he has come from a long way and he cannot return. So you vaccinate him that in July, August only. And but if the patient is a pregnant woman who is in the first trimester, second trimester, then try to convince her कि please come in September, October because the peak of the flu season will hit in November, December, and you are at a critical stage of your pregnancy. You need your immunity at the most when you are in the third trimester. So please try to come later. But if a pregnant woman came and she is already in the third trimester, if a pregnant woman came and she is already in the third trimester, okay, so just imagine a woman who is in the third trimester has come in July, August. So by the time November, December will come, the influenza season will come. By that time, she will already have delivered. Okay, by that time, she will already have delivered. So she is safe from influenza. So should we vaccinate her? Or should we tell her don't take vaccination? You're already safe. When the influenza will come, you will have delivered your baby, so you don't need. See, if you give vaccine to her, it won't affect her, but her child who will be born, that baby will receive immunity. Okay? And remember that 6 months, 6 months was the cutoff. Okay, below 6 months you cannot give influenza to the baby. So the baby is born in November, December, so the baby is at risk for influenza. So if she receives vaccine now, she is not getting any benefit, but the baby will receive passive immunity. So this is the point that you should remember about July and August. And one more group of people who should receive vaccination are the people going on the Hajj pilgrims and people going to mass gatherings. So before they travel, 15 days before, you give them influenza vaccine. Okay? Does not matter it is winter, it is monsoon, because when they are going to such a big gathering, people will come from different parts of the world. Okay? They will be having influenza in their hometown and they are coming to the mass gathering and they can transmit it. So you never know who is a carrier of the virus. So you, irrespective of what season it is in their home city, you vaccinate all of them. Okay, so the vaccine approved is quadrivalent inactivated influenza vaccine. It has been approved. Quadrivalent means four things are covered: H1N1, H3N2. So these two strains of influenza A are covered, and Victoria Yamagata, that means influenza B. So both influenza A and influenza B have been covered in this quadrivalent inactivated influenza vaccine. So this is the recommendation given by this Indian consensus group was formed, which gave this recommendation that if a person is above 50 years, then so there is strong recommendation that they should receive a influenza vaccine. And 18 to 49, if you take the CDC's word, CDC says that you should vaccinate. But if you take the Indian setting where vaccine is costly and there is some sort of immunity in the population, so you can vaccinate in this age group based on the discretion of the doctor and the choice of the patient. If the patient wants to vaccinate himself, he or she is free to do so. So when you manage these patients, first of all, you have to divide the patients into three categories. First, you categorize just like how we are triaging in a roadside accident. Here also we have to divide patient into categories first. So first category is category A, or category A, the uncomplicated patients. Patients who have mild fever. Okay, remember this because this is a difference between category A and B. Here there is mild fever and cough. ठीक है, with or without body aches, headache, diarrhea, vomiting. So they are category A. Here you do not have to test. Testing is not required. Okay, and also do not give them oseltamivir. ठीक है, oseltamivir is the drug of choice for influenza. Oseltamivir is the drug of choice, so you do not need to give them in category A patients. Just tell them to stay at home. Do not mingle with the public. This is category A. Okay. Category B. Category B means still there is no complication, but the symptom patient is having are very severe. So what do you mean by severe symptoms? We mean a high grade fever. High grade means more than 102, and a severe sore throat. ठीक है? If patient is having this, or patient is falling into a high risk group, ठीक है? If a patient is having high grade fever or severe sore throat, automatically he is a category B patient. ठीक है? If he does not have high grade fever but still his age is more than 65, person is pregnant, he is a child, ठीक है? Any chronic illness, see, any chronic illness, extreme obesity, malignancy, immunosuppression, then also the patient will come under category B. So in the category B, ठीक है, the testing is not required. Testing is not required. Okay, patient, you will advise the patient to stay at home, and while staying at home and isolating themselves, they should take oseltamivir. So this is the difference between category A and category B. So what about category C? So category C are those patients who will now require hospital admission. Category A and category B were at home, managed at home. Category A was not given oseltamivir. Category B was given oseltamivir, and category C you are admitting. So when do you say category B? When he has the signs and symptoms of category A and category B and one or more of the following. That means breathlessness, hemoptysis, altered sensorium, seizure, decreased urine output, worsening of symptoms beyond 72 hours, worsening of underlying chronic condition like diabetes, CKD, or he has signs of tachypnea, a fall in the saturation level, hypotension, reduced urine output, cyanosis. Basically, when you think that influenza has the symptoms have now progressed from upper respiratory tract and have gone down to the lower respiratory tract, or have spread to the other organ areas of the body like the kidneys, the brain, then you have to admit the patient. So in these patient, now you will, now you will test. In category A and B you are not testing, but now you will test, and now you will start the patient oseltamivir along with immediate hospitalization and treatment. So when the patient is admitted, general management, obviously we know that patient is having he is having pneumonia, so we are giving him oxygen, which can be through simple oxygen mask, it can be through the NRB, it can be through NIV, non-invasive ventilation, or we may have to intubate and mechanically ventilate the patient. So he may need mechanical ventilation. So since the patient is having tachypnea and fever, it will lead to a state of dehydration. He will be losing fluids. So fluid management is very important. Okay, fluid management, 500 ml NS, 0.9% according to the urine output. Okay, you see the urine output, and according to it we are giving the patient fluids. Okay, what about antibiotics? So antibiotics role is controversial, but if patient is has been admitted, okay, influenza may there is uh, beside compared to other viruses, influenza has the highest chance of being complicated by bacterial infection. Okay, among all the respiratory viruses, influenza virus has a very high chance of being complicated by bacterial infection. So we give antibiotics when the patient is admitted. And among the antivirals, you have to remember that if you have a suspicion, start antivirals immediately. As you keep on delaying antiviral, the efficacy of the antiviral will decrease. So it is most effective when started early in the disease. Okay, you have to start, ideally you have to start within 48 hours of the symptoms starting the of the onset of symptoms. Okay, within 48 hours. Okay, when we are talking about antivirals, broadly there are two classes of drugs. Okay, one is the very famous neuraminidase inhibitors, and second is baloxavir marboxil. So baloxavir marboxil is a new drug. So it inhibits cap dependent endonuclease activity. So basically what it does is the influenza virus, when it enters into the human cell, it takes away the endonuclease. uh, just a minute. It snatches the cap of the host, which is known as cap snatching, and then uses the cap to synthesize its own genome. So that is what the function of the cap dependent endonuclease activity. So by targeting this, the synthesis is inhibited by stopping cap snatching. Okay. And neuraminidase inhibitors. So basically, the host cell, when the influenza virus enters, it enters influenza virus, it will try to proliferate. Okay, it will try to proliferate and then exit from here. So while it is exiting, it needs an enzyme here. This enzyme is neuraminidase. So if we give neuraminidase inhibitor, we are basically stopping the budding or stopping the exit of the virus, and further spread of the virus is being stopped. So this is how neuraminidase inhibitors worked. So we talked about neuraminidase inhibitors. Uh, yeah, we talked about neuraminidase inhibitors. They work on both influenza A and influenza B. So what are they? Oseltamivir, zanamivir, and peramivir. Oseltamivir is 75 mg BD for 5 days. If for treatment, if you're using it for a post-exposure prophylaxis, if you're a doctor who has come in contact with a person having influenza, then for post-exposure prophylaxis, the dose is 75 mg OD, and for 7 days after the last exposure. Zanamivir is an oral drug which is given through the inhalation route, and it is used basically in USA for strains which are resistant to oseltamivir. And peramivir in patients who can't take orally or inhalational, this is an IV drug. IV drug. Uh, what about adamantines like amantadine and rimantadine, which we used to study in the pharmacology classes? They are not used now. Okay? These are historical drugs. They are not used anywhere now. And as I talked about baloxavir, marboxil, which stops the cap-dependent endonuclease activity, it has been approved for age group of more than 12 years old for treatment and for post-exposure prophylaxis.